So for our next speaker, we'll have Dr. Vivek Misra. He's the Associate Professor of Clinical Neurology at Weill Cornell Medical College at Houston Methodist Hospital. He is also actively involved in clinical research in acute stroke management and stroke recovery. He's the site PI for the NIH StrokeNet clinical trials and also serves as the reviewer for various journals. He will be giving us the update on the switch to Tenecteplase today.
Thank you, Dr. Zhang. So we have made the switch to TNK, and these are my disclosures. So when we talk of acute stroke management, the first time we started treating patients with an acute stroke was in 1996 when the FDA approved TPA or alteplase that we know it. And this was when the New England Journal of Medicine published the NINJ TPA trial. This was the pivotal trial, which was, it made tremendous strides in how we treat acute strokes. And then subsequently, as the decades went by, I would use decades because it's over 25 years now, it became clear that the sooner you start thrombolytics, better is the probability of a good outcome. And what it also means is the more you delay treatment, the outcomes will eventually start diminishing over time. Then telemedicine became a standard of care. We have our own robust telestroke program at Houston Methodist. We treat a lot of patients through telestroke. And beyond telestroke now, a lot of institutions, a lot of cities, they're even treating patients in the pre-hospital phase. Before they get to the hospital, we are still using thrombolytics. There are multiple mobile stroke units that are working all over the world in so many different cities. So when we talk of the alteplase infusion or TPA infusion, this infusion we give 10% the bolus of 10% over 1 minute, and the remaining is infused over 1 hour. So it's a 1 hour infusion of TPA. In reality, these patients need 2 IV accesses, one for the TPA infusion, and the second is a lot of these patients will be hypertensive, and we need to lower the blood pressure before we can start the thrombolytic infusion. So that also sometimes takes time. But when we talk of patients who have severe deficits, suspected large vessel occlusions, sometimes the 2 IV accesses may not be enough. So you need 1 IV access for the full TPA infusion. At the same time, we want to do a CT angiogram as well, so that needs another IV. And if they need a cardian drip, which most of them do, then you need a 3rd IV access. So this is a very complex process, which we've been dealing for over 20 years now. In the process, there is a rush to meet the Doten yield times. And for large vessel occlusions, we also have to sprint to the angio suite to minimize the door to groin puncture times. We have to meet all these metrics for comprehensive stroke center certification too. So what studies have shown is since TPA has a short plasma half-life, any gap between the bolus and initiation of the infusion, it reduces the potency of TPA, and you can also underdose those patients. So these are certain practical challenges which have been there with TPA use for the last almost 25 years. So then began the search for new thrombolytic agents. The first one which was investigated was desmoteplase, and this agent was derived from the vampire bat, from the saliva. And theoretically, pharmacologically, it had some benefits, some advantages over TPA. But when it was investigated in clinical trials, these are multi-center clinical trials done in North America, in Europe, and Australia, the results were disappointing. There was no benefit over TPA in terms of recanalization, reperfusion, or clinical outcomes. The second agent, now we come to tenecteplase, which we have now made the switch to. Tenecteplase, or TNK, is a genetically modified mutant TPA. And it is 14 times more fibrin specific, and it's also 80 times more resistant to the effect of the plasminogen activator inhibitor 1. So it has a much longer half-life, about 90 to 130 minutes, compared to about 15 to 20 minutes, which is with TPA. And the advantage is that we just need to give a single bolus injection of tenecteplase to be as efficacious as we would think TPA would be. So the first clinical trial which looked at tenecteplase in ischemic stroke in humans was done in the United States. And the investigators, they looked at 3 doses of TNK, 0.1, 0.25, and 0.4 milligram per kg. When the trial started, it became clear that with the 0.4 milligram per kg dose, there is a higher incidence of symptomatic intracerebral hemorrhage. So that group was stopped, and the trial continued with 0.1 and 0.25. But this trial, unfortunately, was terminated for slow recruitment. What we did find is that TNK was safe. Incidence of bleeding and other complications was similar to patients who got TPA. And there could be some efficacy, but again, it was prematurely terminated, so we don't know what it might have shown. The next trial was done in Australia, and these investigators looked at patients who had large vessel occlusion. They either had an MCA, ACA, or a PCA occlusion proven on CT angiograms. The time window they used was 6 hours, and they investigated 2 doses of tenecteplase, 0.1 and 0.25, and this was compared to another group of TPA-treated patients with large vessel occlusions. What they did find, again, there was no difference in terms of symptomatic intracerebral hemorrhage or adverse events. The higher dose of tenecteplase, 0.25, those patients, they had better outcomes in terms of reperfusion as well as on the outcomes at 3 months. So this was the first trial which really showed some benefit of tenecteplase compared to TPA in patients who had large vessel occlusions. Subsequently, many other clinical trials were done, and in Norway, they did the NORTEST study, which looked at the highest dose of TNK 0.4 milligram per kg. In this trial, it was felt to be as efficacious as TPA without much incidence of side effects, but when they went on to do the more pivotal study called NORTEST 2, the 0.4 milligram per kg dose had a lot of safety outcomes. There was a higher incidence of symptomatic intracerebral hemorrhage, and this trial again was prematurely terminated for all those risks. Another study called EXTEND-IA-TNK was done by the investigators in patients who had large vessel occlusions. All of them went for thrombectomy, and these patients, they were either treated with standard TPA before they underwent thrombectomy, or they were treated with at least 2 doses of tenecteplase, 0.4 and 0.25. So they found that the highest dose of 0.4, it did not give any benefit compared to the medium dose of 0.25, and the 0.4 milligram per kg, again, just like the Norwegian study, there was a higher incidence of bleeding. Another study called TNK-S2B was done comparing tenecteplase, these 3 doses to TPA in a time window of 3 hours. And then the ATTEST study also investigated TPA versus tenecteplase 0.25 milligram per kg, and we'll talk about the outcomes. So how do I, it's not moving forward. So I'm having some trouble moving the slides forward. There it is. So when we talk of the clinical outcomes, looking at early recanalization and reperfusion, the Australian study showed improved reperfusion and recanalization with tenecteplase compared to TP in large vessel occlusion patients. The ATTEST study found no differences, and then the EXTEND-IA-TNK also found improved outcomes with tenecteplase in terms of reperfusion. Another meta-analysis was done which looked at all these clinical trials, and there was a trend towards better recanalization and reperfusion with tenecteplase. Subsequently, the Australians, they did the TASTE-A study in which they treated patients in the pre-hospital phase in the mobile stroke unit in Melbourne, and they compared those to TPA-treated patients, and they found that even in the pre-hospital phase, TNK has a superior rate of reperfusion and outcomes compared to standard TPA regimen. So when we talk of functional outcomes, early dramatic recovery within the first 1 to 3 days, a meta-analysis showed that TNK patients, they did better than TPA-treated patients. And when we talk of long-term outcomes defined as modified Rankin score at 3 months, the EXTEND-IA-TNK, which was a study looking at large vessel occlusion patients, found that there was a trend towards improvement with TNK compared to TPA. And then subsequently, there was a meta-analysis done of all these randomized clinical trials, and they found that there was a trend towards better outcomes in patients who were treated with tenecteplase compared to TPA alone. In China, they did a study called TRACE-2, in which they had patients who either refused thrombectomy or were not eligible for thrombectomy, and they compared in their patient populations a standard TPA regimen to tenecteplase 0.5 milligram per kg, and in their patient population, tenecteplase was non-inferior to TPA. They didn't find any superiority, but they didn't find any side effects as well compared to TPA alone. So when we talk of safety, the highest dose which was investigated, 0.4 milligram per kg, in the Norwegian study, in the first US study, as well as in the Australian study, was felt to be unsafe. There was a higher incidence of symptomatic intracerebral hemorrhage, and subsequently a lot of pooled analyses and meta-analyses were done for all these clinical trials. And it became clear that tenecteplase dose of 0.25 milligram per kg, which is what we use now, when we compare that to TPA, there is no added risk of side effects, including symptomatic intracerebral hemorrhage, angioedema, allergic reaction, extracranial bleed, as well as intracerebral hemorrhages. But how does TNK do when we treat patients outside of clinical trials in the so-called real world? A lot of investigators, and they came across together from North America and Europe, and they made a collaboration called the CERTAIN collaboration, and they published their results just last year. They pooled all their TNK-treated patients, and they were able to demonstrate that the dose of TNK that we now use, 0.5 milligram per kg, in fact, has a lower incidence of symptomatic intracerebral hemorrhage compared to the standard TPA regimen. So how have the guidelines changed? The American Heart Association, they modified their guidelines in 2019, and they recommended TNK 0.25 milligram per kg as an alternative to TPA in patients who had large vessel occlusions eligible for thrombectomy. Those guidelines in 2019, they also mentioned we could use TNK 0.4 milligram per kg, but this is in patients who have relatively minor strokes and those who do not have large vessel occlusion. And this was, again, these two recommendations were class 2B recommendations. What we should notice is that these guidelines, they were modified in 2019, and a lot of these clinical trials were done much later and published much, much later. So the AHA has not changed their guidelines, but the European Stroke Organization, they came out with their own expedited guidelines, and this was barely 2 months ago in 2023. And so the Europeans, they now recommend using TNK 0.25 milligram per kg as a safe and effective alternative to TPA in all patients eligible for thrombolysis. So if there's a patient who is within the time window, who has no contraindication to thrombolytics, they are now recommending TPA 0.25 milligram per kg. The European guidelines, they also mention that if a patient has a large vessel occlusion, then TNK should be preferred to the standard TPA regimen. This is the first time they made a comment that they would prefer TNK to TPA in patients who have large vessel occlusions on the way to the angio suite for thrombectomy. The European guidelines also caution against taking the patient straight to the angio suite and bypassing thrombolytic therapy. So they've really made that clear distinction that TPA, that tenecteplase has to come in and the patients on the way to the angio suite purely because of all the outcomes from the large vessel occlusion clinical trials. So there are clinical trials which are ongoing in different patient populations which we otherwise don't treat with thrombolytics, like wake-up strokes, patients beyond 4.5 hours from the onset of symptoms. So we have made the transition at Methodist Health System to tenecteplase. This was done sometime in May of last year. And we have some prelim data on how are we doing with our patient populations. So from May of 2016 to May of 2023, we had 779 patients who were treated with TPA. And even though the comparison with tenecteplase for TNK, we just had 24 patients. So these 24 patients are early November because we had the 90-day outcomes for those patients by now. So even though the numbers are small, but when you look at the good outcomes, ranking of 0 to 1, as well as mortality, and if you talk of poor outcomes, I think we're doing a pretty decent job with our patient population. So the excellent outcomes with TPA was 55%, 71% with tenecteplase. Again, small numbers with TNK, but at least we know for sure that we are doing a very, very good job with keeping these patients safe and also improving their outcomes, or at the very least achieving outcomes as good as TPA. And this is with patients with large vessel occlusions. So we had 363 patients with LVO treated with TPA in the same duration. And again, small numbers with TNK, just 13 patients. But when you look at mortality and good outcomes, I think with tenecteplase, the switch to tenecteplase has been very efficient, and our patient outcomes have not suffered. I would say we are rather doing better or as good as we were doing with TPA. And I would congratulate all the stroke teams at the different Methodist hospitals for the safe transition, and I would say an effective transition to tenecteplase. And these are the references. Thank you.